Alrighty. Before we get started, I just wanted to clarify because I had a few people email me last time. I do not have access to exam content. I don't get to see the exams. I don't talk to your professors about the exams. So everything I create as far as content, practice questions, practice quizzes, I look at the PowerPoints that you're given and I just pull together what I think is important. So by no means is my review all encompassing. I do think I do a good job at pulling out like key points that are definitely important to know, but just keep that in mind that I don't see the exam. Um, and so I don't know exactly what to talk about, just as a reminder for everyone. But we'll go ahead and get started. I know this exam is a lot of material. It's a lot of different material. Um, so when you're studying these next few days, make sure you break it into chunks. Studying, topic by topic will probably feel a lot more obtainable than kind of jumping between concepts. And I said I'm guilty of this because I think it was for peds this week. I like just try to sit down and study everything, and I'm so overwhelmed. If I can sit down, for this one and study pituitary and just pituitary, that's a lot more obtainable than looking at the list of topics I have to cover. Another good tactic is talking out loud. It might be silly, but just pretend like you're explaining the topics to your patient or to a family friend who maybe doesn't know much about the topic. Um, and guys, this is your last exam before your final. That's crazy. You guys are almost there and you're doing incredible. Um, so yeah, and I put a note in there. You guys all have my past tutoring slideshows, so there are more study tips in there if you want to go ahead and review those as well. But you guys are all going to do great. You have been doing incredible. So, alrighty, we're going to go ahead and get started with the pituitary gland. So the pituitary gland is the master gland that regulates hormones. It is controlled by the hypothalamus. That's that part of the brain that acts as kind of the middleman between signals sent from the body to the pituitary. And the pituitary is divided up into the posterior and anterior sides. There are three hormones to know that come from the anterior side. That's your adrenocorticotropic hormone, or ACTH, your thyroid stimulating hormone, which will be super important here in a little bit, TSH, and your growth hormone, GH. Your posterior hormone, the one that you need to know is the antidiuretic hormone, that ADH, also is referred to as vasopressin. So there are a bunch of different abnormalities that can happen with the pituitary gland. You've got hypopituitarism. Oh, hypopituitarism, sorry. This is the undersecretion of hormones from the pituitary, and this is typically from just disease of the pituitary or the hypothalamus, and that can be caused by a bunch of different things. And then you have hyperpituitarism, and this is the oversecretion of a gland. A lot of times, too, the hormones end up being impacted by a pituitary tumor. These often aren't cancerous tumors, but they do still impact the function of the pituitary gland. Functional tumors are tumors that do secrete hormones. So these can really mess up someone's hormone level and the implications in the body, whereas non-functional tumors don't secrete hormones. The basophilic tumor can cause Cushing's syndrome. A chromophobic tumor is a tumor that does not secrete hormones, but it actively destroys the gland. So that in of itself would cause a lot of issues, likely of hypopituitarism. And then you have a eosinophilic tumor, and these can cause gigantism or acromegaly, which we'll talk about here in just a moment. So gigantism, this is excess of the growth hormone from the anterior pituitary early in life. That's a key difference here. With gigantism, the patient will grow very tall and large, and it's in proportion across the body. So these people have lanky arms, lanky legs, their trunk is long, and they're tall. It's all proportional. And because of this, the patient might also have generalized weakness and fatigue. They might be lethargic, and those are just associated symptoms with gigantism. Then acromegaly is the excess growth hormone in adulthood. So that's what distinguishes it from gigantism. Acromegaly, with this one, growth is going to be limited to feet, hands, molar eminences, nose, and chin. So this growth is not proportional across the body. There was a picture in your professor's PowerPoint But like the nose was very large and maybe the ears were very large, but the rest of the facial features were, they appeared to be of a more expected size. So this is not proportional growth. Acromegaly can cause bone weakness, impaired glucose tolerance, and then hyperinsulinism and insulin resistance. So this would be something to really pay attention to, especially in your patients with diabetes. So then a medication for acromegaly is octreotide acetate. This is the prototype drug for acromegaly, and it decreases the secretion of growth hormone. It does have some adverse effects, mainly impacting the CNS, the cardiovascular system, and then it can also cause issues with blood sugar. The main nursing implication to know is that there are multiple routes for administration. It can be IV, IM, or sub-Q. Like most sub-Q injections and routes, you're going to want to rotate injection sites. So if you do, the back of the arm, one dose, maybe try the abdomen for the next dose or the back of the thigh, those different subcutaneous sites that we know of. And then to be able to monitor effectiveness, you're going to need to withdraw the drug for 4 weeks once per year. That's something pretty unique that we don't do often with medications. But yes, you'll do that with octreotide acetate. So then on the other side of the spectrum, dwarfism is caused by insufficient growth hormone from the anterior pituitary, and it just basically causes slow or stunted growth. So then this is treated by a synthetic growth hormone, which is somatotropin, and this stimulates skeletal and then linear muscle and organ growth. The drug is not going to be effective once long bones have closed, which you can see in, like growth plates, in scans and testings. So yeah, like in an adult who is when their long bones have closed, somatotropin is really not going to do much for them. So this is typically given to younger populations. Adverse effects aren't super common with somatotropin since it is just a synthetic hormone, but it can cause hypoglycemia, especially in those patients with diabetes. And then dwarfism is evaluated, or sorry, not dwarfism, somatotropin, the effectiveness is evaluated by growth. So you're going to pay attention to growth, and when the growth of your patient is satisfactory, that is when the provider will go ahead and discontinue the medication. Going further with pituitary disorders, one is diabetes insipidus. And I remember this one for me really tripped me up because when I see diabetes, I'm instantly thinking blood sugar, insulin, hypoglycemia. And this is not the case for diabetes insipidus. Diabetes insipidus is a deficiency in ADH. So this condition causes large volumes of dilute urine and extreme thirst. The most common cause is head trauma that's affecting the pituitary. And the clinical manifestations are that really large amount of dilute urine and then extreme thirst. And as a result, you have all the signs and symptoms that you would expect with dehydration. Desmopressin is the pharmacological treatment for diabetes insipidus. It is a drug that replaces that ADH that we're deficient in. So it works to increase that reabsorption of water to reduce that, dilute urine excretion. For desmopressin, there is a black box warning for severe hyponatremia. And if you remember from the last unit where we had so much fun with electrolytes, hyponatremia can cause seizures and death. So that is definitely something to keep in mind. And the effectiveness of the treatment is going to be monitored by a decrease in the urine output and then decreased signs of dehydration and then also decreased signs of that like excessive thirst that I was talking about. So then in opposition to diabetes insipidus, we have syndrome of inappropriate ADH. And this one is going to be excessive ADH, like I said. So you have increased fluid volume and water retention intoxication. Manifestations here are going to be low urine output, high ADH, hyponatremia, overhydration, and you still see the excessive thirst that's also present in diabetes insipidus. So I pulled this from your professor slide. Definitely be able to list these when comparing diabetes insipidus and SAADH. Again, one is too little ADH, one is too much ADH. The symptoms are pretty much exact opposites, except they both will present with that excessive thirst, as shown at the bottom there. Alrighty, here are the practice questions. So just per usual, if you just want to put them in the chat or unmute yourself, I would appreciate it. Which of the following hormones is secreted by the posterior pituitary? Alrighty, yeah, that one is C. A, B, and D are all produced by the anterior pituitary, but ADH is that. Um, sorry, I'm blanking. Posterior pituitary hormone. Which of the following clinical manifestations is not characteristic of diabetes insipidus? If you guys two are worried about being wrong, you can message me directly and you don't have to put them in like the public chat. Awesome. Okay, I have a few coming through. You guys are correct. The answer is B. Um, Diabetes insipidus is the insufficient ADH, whereas SIADH is that excess. So that's the one that does not fit. When is somatotropin no longer an effective treatment option for dwarfism? You guys are all correct on this one. This is when the patient's long bones have closed. And sometimes that coincides with, reaching adulthood or whatnot, but the key note to remember is that when long bones have closed, that's when it's no longer effective. Alrighty, so that was all for pituitary. So now we're going to go ahead and move forward to the thyroid gland. The thyroid gland is responsible for secreting three main hormones, and we'll talk about them a little bit more. There's T4, which is thyroxine, T3, which is, I'm not even going to try to pronounce that. I'm too tired. And then there's calcitonin. Calcitonin is secreted in response to high calcium, and it works to decrease calcium level. In my brain, I always thought that would be the opposite because it sounds like calcium, so it probably increases calcium, but it's the opposite. It just reduces that blood calcium level. For the thyroid hormones, iodine is required to produce these hormones. So this is, part of the diet, part of medications, just in the body. But your thyroid needs iodine to produce these hormones. T3 and T4, those main thyroid hormones, they work for cellular metabolic activity and cellular replication. So they are super, super, super important for your body's overall, cellular function. And then where thyroid stimulating hormone comes in, that is the hormone that controls secretion of T3 and T4 from the thyroid. So, if your T3, T4 levels are low, your hypothalamus will stimulate your pituitary to go ahead and signal for more to be made. And then once that is at the appropriate level, that signal comes to stop the TSH coming from the pituitary. So it's a big feedback loop there. That's how, pituitary then controls the thyroid. And again, it's the master gland for a reason. So some lab diagnostics to be familiar with. You have serum TSH, primary tool for screening. This is just going to help you adjust, especially with thyroid replacement therapy. You start giving it and then it's way too high. You can kind of back off on the dosaging. There's free T4, which measures that free thyroxine. And then there's T3 and T4 lab values, measuring the free and bound T3 and T4 hormones in your body. And those increase and decrease together. So they are both stimulated by TSH, so they're going to move together. Alrighty, so hypo, that says parathyroidism. We're going to ignore that. I will change that before I send it to you guys. Hypothyroidism is what we're talking about here. It is the most common type is just primary or thyroidal hypothyroidism, which is just the dysfunction of the thyroid gland. It is most commonly caused by Hashimoto's disease, which is the autoimmune condition that can impair the thyroid. So then clinical manifestations are all going to be related to reduced cellular metabolism, um, and reduced cellular replication. Sorry. So you're going to see things like fatigue, weakness, weight gain, your cellular metabolism is slow, um, dry skin, hair loss, bradycardia, slow thought processes, things like that. And then mixed edema, we'll talk about here in a moment, but that is indicative of a severe case of hypothyroidism. So, myxedema coma is a life-threatening condition that is caused from severe hypothyroidism, that can develop into cardiovascular failure and shock and ultimately death. Um, Myxedema coma typically happens when someone is, non-medication compliant or unable to, or just hasn't gotten treatment for their hypothyroidism, or there is some, you know, external event that causes their hypothyroidism to exacerbate a little bit. With myxedema coma, the patient will be hypothermic, unconscious, and they'll have a very low respiratory rate. And this is all in relation to that significantly decreased cellular activity from the hypothyroidism. The treatment, you're going to be monitoring respiratory status and pretty much prepared for mechanical ventilation. Passive rewarming here will be important, and then cautious use of fluids as well, just staying on top of vitals, all those typical things. For treatment for hypothyroidism, the main medication or drug of choice is levothyroxine. This is a synthetic thyroid hormone. And you can, titrate the dose to the desired level. So you're constantly going to be checking those thyroid hormone levels while you're taking levothyroxine. And really, the adverse effects are just going to be signs and symptoms of hyperthyroidism if your dose is too high. You've now put too much synthetic thyroid hormone in your body, so you're getting the opposite effect. So it is kind of a bit of trial and error to find where that sweet spot is for treatment with this one, with a lot of these actually. So then you have the opposite. Now it's hyperthyroidism. This is most commonly caused by Graves' disease, which is an autoimmune condition. Um, so Graves is to hyperthyroidism as Hashimoto's is to hypothyroidism. With Graves' disease, there's excess output of thyroid hormone, and generally an overall increase in body metabolism. So all of your signs and symptoms now are going to be in relation to that increased metabolism and oxygen consumption. So you're going to be looking at anxiety, tremors, tachycardia. Patients can have bulging eyes, increased drug metabolism, and weight loss. Sorry, I did not mean to do that. Thyroid storm is the acute release of excessive thyroid hormone. So this is life-threatening, and it's typically caused by an ablative dose of iodine, which again is um, that substance is needed for thyroid hormone production, or just poor treatment, under treatment of that hyperthyroidism. So symptoms will be tachycardia, fever, circulatory collapse, and arrhythmias. For treatment for hyperthyroidism, radioactive iodine is the treatment of choice. With this one, a single dose is mostly effective, um, and it produces hypothyroid. It will just kind of not destroy, but significantly inhibit the thyroid's ability to continue with that excess thyroid hormone production. So as a result, the patient will need essentially lifelong hormone replacement therapy. Um, it's one of those instances where pros versus cons, if it's decided that, hypothyroidism with that hormone replacement therapy is safer for you than chronic hyperthyroidism, then, that's what will be done. Um, Another treatment is propylthiouracil. This medication inhibits the hormone release, and it does take a little bit to take effect. So that radioactive iodine is pretty much instant. The propylthiouracil can take days to weeks to reach its effect. There are adverse effects, just like radioactive iodine. You can induce hypothyroid symptom, signs and symptoms. You can also have leukopenia and liver failure, and that can happen with radioactive iodine as well. So some adjunctive treatments, there are iodine preparations, the Lugol solution, as well as a saturated solution of potassium iodide. These are used short term and they cannot be used with those primary drugs of the propylthiouracil and radioactive iodine, but they have similar effects on those on the thyroid. And then propranolol is another medication that can be used in, adjunctive treatment. It is a beta blocker and it can control the cardiovascular symptoms that come with hyperthyroidism. And then another option is that surgical removal of the thyroid if it is serious enough. Alrighty. What is the drug of choice for hypothyroidism? Awesome. Yeah, you guys are correct. That is levothyroxine. We did talk about all the other three, but octreotide acetate is that for acromegaly. And then the bottom two are going to be for hyperthyroidism. Alrighty, which of the following statements is not true regarding Graves' disease? Okay, yes, this one is C. Graves is indeed an autoimmune condition causing hyperthyroidism. So it causes excess thyroid hormone production. C would be indicative of Hashimoto's disease, not Graves' disease. Alrighty, now we're going to move on to the parathyroid. The parathyroid is a gland kind of surrounding the thyroid in the posterior aspect. There are four parathyroid glands. And the parathyroid hormone or parathormone, it's used a little bit interchangeably. It regulates calcium and phosphorus metabolism. So with hypoparathyroidism, it's exactly what it sounds like. You're going to have low parathormone secretion. It's typically actually caused by removal of the thyroid gland in cases of hyperthyroidism. Um, and hypoparathyroidism coincides with calcium, so it causes hypocalcemia, low calcium. So the clinical manifestations there are exactly the same as as those of hypocalcemia. So you're going to see tetany and cardiac arrhythmias. So with hypoparathyroidism, you're thinking low calcium, and the treatment there is really to just treat the cause or increase your calcium intake because all of your symptoms are from the hypocalcemia. Um, in opposition, then you have hyperparathyroidism, which is that overproduction of the parathormone. These symptoms are going to be more in line with hypercalcemia, and you can also have bone decalcification as well as kidney stone formation. And then you can still have heart arrhythmias with that increased calcium concentration as well. The main treatment here is going to be removal of the parathyroid via parathyroidectomy. But for nursing interventions, you can work on focusing on hydration to prevent those kidney stones and mobility to help with that decalcification. If someone does get their parathyroid removed, in the post-op setting, you're going to want to monitor for tetany because they can have, pretty onset, like calcium drops with that. Pretty quick onset, sorry. Alrighty, true or false, hypoparathyroidism symptoms are the same as symptoms of hypocalcemia. You guys are correct. That one is true. Alrighty, there is not too much on parathyroid. I didn't want to spend too much time on it because there's a lot to cover for you guys. Alrighty, so next is the adrenal gland. The adrenal gland has both the medulla and the cortex, being different parts of it. The medulla is the part of the gland that is responsible for norepinephrine and epinephrine. And you learned a lot about these during the first unit, the neurological, those cascades and everything with the cholinergic and anticholinergic and all those things. Um, so that's regarding fight or flight primarily. Um, and then the adrenal cortex releases glucocorticoids, mineral corticoids, and the sex hormones or the androgens. So those are kind of what fits where. A pheochromocytoma is a tumor of the adrenal medulla. So we just talked about the adrenal medulla dealing with norepinephrine and epinephrine. So we'll just kind of keep that in mind. Because the clinical manifestations of a pheochromocytoma are going to be hypertension, which, can be without taking blood pressure. Um, Hypertension can be indicated by the headache, diaphoresis, and palpitations. You can also see hyperglycemia, headache, hyperhidrosis, and hypermetabolism. Um, Treatment really for this type of tumor is going to be surgical removal. But when you think of pheochromocytoma, I want you to think of blood pressure. That is the most important thing. It can cause pretty intense hypertension. So prior to surgery, we're going to get that blood pressure under control with medications. And then during the actual procedure, your patient is at risk for a hypertensive crisis, when you're just messing with the adrenal gland like that. But once it's actually removed in the post-op scenario, they're at risk for hypotension. So being super, super on it with blood pressure checks and how they're feeling and those types of things and that medication management will be super important. Then Addison's disease is adrenal cortex insufficiency. So that's where the glucocorticoids, mineralocorticoids, and sex hormones, the androgens, are from. And Addison's is that insufficient production of those in the adrenal cortex. So clinical manifestations are going to be you're going to have increased excretion of sodium chloride and water, but you are still going to retain potassium. So you're entering, hyponatremia, hypochloremia, but hyperkalemia. And I hate that all the electrolyte balances continue through, but they truly do. They're pretty important for a while here. So you'll also see decreased cardiac output as well as low blood sugar. Some labs to expect with Addison's disease would be that low sodium, the hypoglycemia, and then that hypernatremia, and then leukocytosis with the white blood cells. Addisonian crisis is a life-threatening exacerbation of Addison's disease, typically in response to stress or illness or some other external factor. Clinical manifestations would be the onset of severe hypotension, cyanosis, fever, nausea and vomiting, and it all can lead to shock. And then also a craving for salt, and that's just from your hyponatremia and hypouremia. Treatment for Addison's disease, there are two main medications, and these are steroids because the adrenal cortex is a steroid production center. So it makes sense that when you have an insufficiency in the adrenal cortex, you're going to treat with steroids. One of them is hydrocortisone. This is a combination of a mineralocorticoid and an adrenocorticoid. It decreases inflammation and increases sodium retention, so you're going to combat that hyponatremia. And then with fludrocortisone, it is specifically a synthetic mineralocorticoid, and it'll still promote that Na retention, the sodium retention, and it'll actually challenge the hyperkalemia with the potassium excretion. Some of the side effects here are going to be hyperglycemia, so we're still working in opposition. Just, you know, if with Addison's disease you're at low blood sugar, if you try to treat it, you are at risk for high blood sugar then. Hypokalemia, if you overcorrect that potassium retention. It can cause CHF and hypertension, and it actually can also cause gastric ulcers like any steroid really can. So there's a lot to kind of keep an eye on when it comes to these medications. So in opposition to Addison's disease, Cushing's syndrome is the oversecretion of glucocorticoids and androgens from the adrenal cortex. So now we have too many of all of those. And it's actually most commonly caused by the use of corticosteroids, steroidal medications, because now you're introducing additional steroids to what your body's producing. So clinical manifestations here are pretty much directly in opposition to those of Addison's. You are at risk for obesity, you'll have fragile skin, fragile bones. You get a moon face, which you get when you take steroids. So a lot of the signs and symptoms of Cushing's syndrome are similar to adverse effects from steroids. That moon face is just a lot of facial swelling. You're at an increased risk for infection, increased risk for hypertension and heart failure, and then that high blood sugar as well. Ketoconazole is a medication option for Cushing's syndrome. It inhibits the enzymes needed for cortisol synthesis. So when there's that excess, this will be an option to kind of halt that production. Something to note about it, though, is that it can cause liver toxicity. This is just a visual I found, some good, what's the word I'm looking for? Just like memory tricks to remember Addison's versus Cushing's disease and how they kind of present in a clinical setting. Alrighty, and then primary aldosteronism. This is a condition of excessive aldosterone production. Um, this typically presents with hypertension, polyuria, very concentrated blood because you are urinating more, excessive thirst, increased blood volume, and hypokalemia. It is typically caused by a tumor on the adrenal gland. So surgical removal of the tumor is the primary treatment there. Um, and in the post-op setting, when you're really messing with any kind of gland, you're going to want to monitor for fluctuations in those hormones because you know, surgically interfered with the body's process of regulating hormones. So just monitoring those and administering synthetic ones or, you know, medications to halt whatever is being produced would be important. Corticosteroid therapy then is used for adrenal insufficiency. Like any steroid, it's going to suppress inflammation and also the immune response. But it can also be used to reduce transplant rejection odds. And like I said, the adverse effects here are very similar to those of Cushing's. So you got the hypertension, the infection risk, poor healing, high blood sugar, moon phase, weight gain. There's a lot of similarities. And I know it feels like a lot right now. It's a lot even just talking about it. But once you kind of connect the dots as to what matches what, you'll be able to identify what symptoms go with which condition and which adverse effects to expect. Ready? Which of the following are symptoms of an Addisonian crisis? I forgot, I meant to put select all that apply there too. This one's all of them, so you guys are right. I should have put select all that apply in the question, but yes, this one is all of them. All of these would be indicative of an Addisonian crisis. If you know someone like in their chart has Addison's and you start seeing any of these signs or symptoms, you're going to want to make sure that they're not going into that crisis state because it can lead to that shock. Which of the following hormones is released by the adrenal medulla? There's just one here. So yeah, that is epinephrine. A, B, and C are all released by the adrenal cortex. Which of the following medications are used to treat Addison's disease? Select all that apply. Awesome. Yeah, you guys are all correct. That is A and D. B is for Cushing's disease, and C is for dwarfism that we talked about earlier. Alrighty, so that is everything endocrine. And I'll be so honest with you guys, I do not like the endocrine system. I understand it to the point that I need to understand it, but learning about it just stresses me out. So I'm right there with you if you do feel that way. Like I said, breaking it down, you know, topic by topic and really focusing on you know a lot, like you truthfully do. So looking at what you understand in the body, you can, you know, slowly start piecing those pieces together that feel super overwhelming. But with that time and effort, and again, that focus study, you guys will all get it down. And you've been doing great so far. So the next section is hemostasis and anemias. So yeah, we'll just go ahead and get started. I think I focus primarily on the anemias in here. For clotting pathways, there are two main ways your body initiates a clotting cascade. There's the extrinsic clotting pathway. This is the one that like I would say most people think of when they think of clotting. It's the faster pathway. It's activated first, and it's activated in response to injury. um, you get a cut or a scratch and it's going to bleed and it's going to stop and clot pretty fast. That's that extrinsic clotting pathway. Whereas intrinsic is a slower process and it occurs when the interior blood vessels are exposed to lipoproteins or bacteria. So this is more of like a I mean, they're all self-defense, you know what I mean? But this is like a self-preservation in the response to like an invader without necessarily an injury. So that's that clot formation without bleeding or injury. Clot destruction, then, there's like a kind of a cascade of hormones and enzymes that work to destroy a clot. But in quick bullet points, plasminogen is a circulating substance that's then activated into plasmin. And the plasmin, when it comes into contact with the fibrin and fibrinogen, which are structural components of a clot, they begin to dissolve it, and then the clot is able to dissolve. Um, so plasminogen to plasmin that digests the structure of the clot, and that allows the clot to dissolve. So anemia in general is defined as a low number of red blood cells, hemoglobin, or both. And ultimately, this causes decreased oxygen to tissues. Um, a major cause is bone marrow damage, but also there's a lack of that erythropoietin and certain nutrients like iron, B12, folate. Um, Again, bone marrow because that's where all of our red blood cells and immune cells are produced. So that's a major, major cause of anemia. Clinical manifestations have a wide variety of presentation as far as severity and onset, and that just, really depends on what the blood levels are for RBCs and hemoglobin. But you can expect to see varying levels of pallor, tachycardia, dyspnea, fatigue, hypotension, and then headache, dizziness, and lightheadedness. Anemia is one of the most common hematologic disorders in older adults, and it's also just super common in general. We'll talk about the different types here, but I have iron deficiency anemia. A lot of people do, especially like young women and teens who have begun their menstrual cycle. Um, People who don't eat meat. There's just a lot of different risk factors that can lead to anemia. And while it can be dangerous, especially depending on the types, it is super common. One type of anemia that there's not too much about it. It's blood loss anemia. So this is just a loss of those red blood cells through blood loss, whether that's acute hemorrhage or just chronic bleeding, clotting, menstrual disorders. So this isn't an issue with the red blood cells or hemoglobin themselves. This is just you're losing blood and your body's not getting the oxygen that it needs. Like I mentioned, iron deficiency anemia is a type of anemia. Iron is a nutrient required to make hemoglobin. So with iron deficiency anemia, the body cannot effectively synthesize hemoglobin or make enough of it. Um, so causes here are blood loss. Like I said, menstruation can be a cause, pregnancy, alcohol abuse, or NSAIDs as well. Diagnostics, you're gonna do lab values for ferritin, that's an iron store, and then also hemoglobin will be lower, again, because it doesn't have the iron to produce as much of it as is needed. Like all anemias, symptoms vary with severity, and they can range from just minor headaches and fatigue, to pretty impairing shortness of breath, palpitations, weakness, etc. For iron deficiency anemia, there are some medications that we can do to try to reduce symptoms and help with that iron intake. So there's ferrous sulfate. This is an oral medication. It's basically an iron supplement. Common adverse effects here are going to be nausea, dark or black stools, constipation, and teeth staining. And a toxicity is liver damage. So you'll want to educate that, the black stools and the constipation it's unfortunate, but it is expected. And you definitely want to tell your patient that so they don't get home and freak out if they do see that their stool is black. But you're going to want to keep out for signs and symptoms of liver damage as well on a more serious level. And then iron dextran is given IM or IV. So this is not an oral medication. It can cause like local irritation. That's why if you give it IM, you want to use the Z-track method, which I think you guys learned in skills. That's basically just like pulling the skin so that it doesn't get out of the muscle. The IV preparation of iron dextran is given diluted and over several hours because there's an increased risk for anaphylaxis with this medication. And then the patient is also at risk for tachycardia and hypotension with iron dextran administration. So then another type of anemia is aplastic anemia. This is decreased bone marrow stem cells, and that's from damage to the cells or the bone marrow itself. Um, and like I said, bone marrow is where these cells are produced. So if you're damaging the bone marrow, you're going to have pretty significant issues. And that's why aplastic anemia comes with pancytopenia, which is low everything, everything, low red blood cells, low white blood cells, and low platelets. The terms for those you'll see pretty common. I would definitely be familiar with pancytopenia and what that means. Um, Aplastic anemia can cause life-threatening infections and bleeding because you can have low the white blood cells for infection and platelets for bleeding. And it can be congenital, and it can also be secondary to drugs. Sometimes things like cancer drugs especially can cause it with damage to the bone marrow. So then here are those clinical manifestations. It's all the implications of pancytopenia. So neutropenia, you're at an increased risk for infection. Erythropenia, that's that anemia, low red blood cells, and thrombocytopenia, low platelets, so you're at risk for bleeding. Treatment here is supportive primarily. You're going to be constantly assessing for bleeding and infection. And then there are some medications that we can do to stimulate the growth and production of white and red blood cells. That's epoetin alpha and filgrastim. So epoetin alpha stimulates the growth of red blood cells. Um, there are some side effects here. They can have hypertension, joint pain, and then the trio of nausea, vomiting, and diarrhea. There is also a black box warning for epoetin alpha. If you give it when hemoglobin is above 12 or like in a normal range, the patient is at risk for developing a thrombus. So prior to epoetin alpha administration, you want to know what their hemoglobin is to prevent a thrombus. And the effectiveness is measured by improving hemoglobin. So again, you're going to be constantly measuring that level there. So epoetin alpha deals with red blood cells. Filgrastim is the medication for white blood cells. So this challenges leukopenia. Um, and because of that, it in turn prevents infection by decreasing the patient's neutropenia slash increasing the neutrophil count in their body. Megaloblastic and macrocytic anemias are grouped together. They are the folic acid deficiency anemia and pernicious anemia. In these anemias, red blood cells are large and abnormally shaped. People can be pretty asymptomatic until this gets severe. And if it's folic acid deficiency anemia, it's caused by exactly what it sounds, a folic acid deficiency. But pernicious anemia is caused by a vitamin B12 deficiency. And the thing with pernicious anemia, someone could be consuming enough B12, but a key characteristic is that there's an absence of an intrinsic factor, which is required for B12 absorption. So with that absence of intrinsic factor, even if you're getting all the B12 that you need through your food and through supplements, you're not going to absorb it. So because of this, if someone has pernicious anemia, and that absence of their intrinsic factor, oral vitamin B12 is not going to work, no matter how many times you give it. So that's when we start looking at like injections of B12 or IV supplements of B12. Clinical manifestations are the same symptoms as anemia, but something that makes it unique is a patient might present with a smooth, sore, and red tongue to kind of differentiate it from other anemias. And pernicious anemia, if kind of either untreated or just gone on too long, can cause some neurological symptoms. And that's just related to vitamin B12's like role in your neurological system. So diagnostics, you're looking at the folate levels for that folic acid deficiency anemia, B12, and then also you're going to want to ID if the patient has that intrinsic factor, and there is an intrinsic factor antibody test for that as well. So again, B12 replacement if pernicious anemia, but it has to be not oral in that instance. If someone's just B12 deficient, they're not necessarily diagnosed with pernicious anemia because they might still have that intrinsic factor. And in those cases, oral B12 is okay. But if it's truly pernicious anemia, oral B12 will not work. And then folic acid for folic acid deficiency anemia. Hemolytic anemia is what it sounds like. There's that lytic ending there, so things are breaking. So there's decreased red blood cells circulating because of a shortened lifespan. Hypoxia, which is a result of the hemolytic anemia, will create a feedback loop that stimulates more production, but the red blood cells, no matter how many you're making, they're just dying too fast because of a variety of different characteristics that just make them basically break and die before they can effectively carry oxygen. Um, yeah. Sickle cell disease, super important to know about. It's a hereditary disease where the hemoglobin is in an abnormal sickled shape. So not only does this cause an issue with its capacity to carry oxygen, but it can adhere to the cell walls in vessels, in those small vessels, and that can impair blood flow, causing ischemia. And that can cause pretty intense pain and swelling in the affected area. Clinical manifestations of sickle cell disease go beyond just those of anemia. So there is chronic anemia, but you might also see things like jaundice, bone abnormalities, as well as pretty severe ischemic episodes. Those are also referred to as a sickle cell crisis, those ischemic episodes. If someone comes in to the hospital with a sickle cell crisis, there is kind of a protocol as far as treatment goes. Their oxygen level is going to be number one priority. Um, Opioids for pain control related to the ischemia is super, super important. And patients with sickle cell oftentimes get labeled as drug seekers, and there are a lot of stereotypes that exist there. But truly, sickle cell can cause so much pain that opioids for pain control are pretty standard. So, you have to believe what the patient's pain is. If their pain is a 10 out of 10, their pain's a 10 out of 10, and you need to treat it like it's a 10 out of 10. So you'll see opioid prescriptions. You'll do IV hydration. You're going to want to do warm compresses for the affected area because cold compresses will worsen ischemia with vessel constriction. And then someone with sickle cell may also need blood transfusions. While there are medications that we're about to talk about for sickle cell, there is not a cure for the condition yet, at least. There's so many research, like trials and studies going on for it, though, that I do know. So, hydroxyurea is the medication primarily used for sickle cell management. It decreases the initial formation of sickled cells, and because of that, you're going to reduce sickle cell crises and basically promote effective hemoglobin and oxygen perfusion. So that just helps reduce those effects of untreated sickle cell syndrome. Nursing management, like I said, with those acute crises, think O2, pain control, hydration. Those are your big ones. And there are also lifestyle modifications that can be made to help those symptoms, as well as, yes, identifying triggers of a crisis. A lot of times there's, a stress or a certain environment or even being out in the cold, which isn't the most avoidable. But if you can help them identify their triggers, you can help prevent those crises a little bit more. Even something like getting sick with a cold can trigger a sickle cell crisis. So just helping your patient work through those triggers will be helpful. Thalassemia, this is an inherited condition. It's most common in the regions of the Mediterranean, Africa, and Southeastern Asia. This causes impaired hemoglobin synthesis, which kind of like hemolytic anemia leads to premature red blood cell and hemoglobin destruction or rigid cells, which are then not able to carry oxygen effectively. Yeah, that's thalassemia. It's pretty straightforward. I would just know like kind of where it originates from and how it impacts those hemoglobin cells. Polycythemia, this is increased erythropoietin production. So now there are too many red blood cells. This whole time we've talked about too little red blood cells. This is kind of the one instance where you're going to see way too many. So as a result, you have hyperviscosity of the blood and an increased blood volume. And it can actually turn your, like, someone with polycythemia might look really red because they literally just have that much blood inside of them. Most commonly caused by hypoxia. So there's that feedback loop of we're going to keep making more red blood cells in hypoxic conditions. So if you're in kind of a chronic hypoxia, like a patient with COPD, they're at an increased risk for polycythemia. And the treatment here is kind of unique. It's not a medication like we usually talk about. It's therapeutic phlebotomy to decrease the circulating blood volume. So this is genuinely like drawing blood and just getting rid of it so that there's less blood circulating. Also, like with anything, treating the underlying cause. In the example I gave, if this patient with COPD is going through a COPD exacerbation and develops polycythemia, the primary goal should be to get the COPD under control. And in turn, that erythropoietin production should slow down as well. Neutropenia is a low neutrophil count. Neutrophils are major, major players in fighting infection. So with neutropenia, you're at an increased infection risk. Neutropenia by itself won't really have any symptoms, but in a patient who is neutropenic, you have to initiate precautions to protect them from infection. Those are those neutropenic precautions that you see when talking about like isolation and transmission control. Alrighty, guys, last few practice questions here. Which of the following medications is used for sickle cell? Okay, yeah, that one is C, that's the hydroxyurea. Which of the following medications would reduce someone's risk for infection? This one's a little tricky. It's not A. A would be for a patient with pernicious anemia to help with that. This one is D. So B12 is for pernicious anemia. Epoetin alpha is for those red blood cells to increase production. And then fulgrastim is the medication that increases white blood cell. Yeah, white blood cell count. And white blood cells are what defend against infection. So fulgrastim directly would reduce someone's risk for infection. Which of the following interventions for a sickle cell crisis would be inappropriate? Awesome. Yep, that is ice pack. Heat is going to be used if someone is experiencing ischemia in their arm. Heat would be ideal over ice in that situation. A, C, and D are all expected interventions. Which of the following is false regarding ferrous sulfate administration? Okay, yep, that one is C. Um, Ferrous sulfate is given PO, whereas iron dextran is the one that's given IM or IV. Alrighty, so it's already 8:25, so I'm not going to go over it on the Zoom, but I did prepare, I can pull it up briefly. I did prepare another practice question quiz here with answers and rationale, so I will send that to you guys on a separately from this Zoom. But that is everything I have for you guys. I hope that this was somewhat helpful here. Here is the QR code if you did miss it. And then after this, I am going to email the material to all of you guys as well as your professors to share with the class.